So, physiotherapists are typically not trained in nutrition or in gut health. And yet, I don't think we can deny the emerging evidence that gut health and the fact that two-thirds of our immune system lines the gut and its role in inflammation, the role that plays in core control. And in the people that we see that are often diagnosed with fibromyalgia or polymyalgia or multiple muscle pain syndromes, a lot of these people come in and they've got a Diet Coke in their purse and they're chewing sugar-free, they're eating aspartame, and they have no clue that what they're feeding themselves may be contributing to their headaches, bladder cystitis, back pain, the complex person with multiple comorbidities that are excluded from all trials because they're too complicated. These people often I will start with gut health. There's so many reasons why we can't treat the human being like a building or a machine. So I'm excited for our future, and I think there will always be therapists who are better at education and training. There will be therapists who are better at manual methods, and the best people will be the ones that can educate, use their hands, use touch to change the nervous system, use touch to change whatever it is we're changing, and also help people to move better, to train better, to get stronger, to be fitter, to eat well, to do all the things we need to do to keep the home we live in, named our body, as healthy and as efficient as we age.
FC2O. From chaos to order. From chaos to order. Here we go. From chaos to order. From chaos to order. FC2O.
This week, I'm excited to tell you that we have the world-renowned physiotherapist Diane Lee on FC2O with us. I've been lucky enough to know of and latterly to get to know Diane for a couple of decades now, and she is a whirlwind of knowledge, ideas, insights and passion for all things pertaining to helping optimize the therapeutic landscape. As a thought leader and author of multiple highly prized textbooks and papers, Diane is a real treasure in the field of manual therapy and rehabilitation. Recently, I've had the good fortune to co-author a paper with Diane for the Journal of Bodywork and Movement Therapies, which is available for free for just a few weeks, so details of how to access that are in the show notes. Now, before we get going, I want to tell you a quick story about Diane. 3 or 4 years back, I was sat in a coffee shop with a friend of mine who used to run the largest continuing professional development company for manual therapists in the UK. He provided courses with anyone who was anyone on the global stage, from Shirley Salmon to Lorimer Moseley, or Douglas Heel to Paul Hodges, and including, of course, Diane Lee. And so I asked him, out of everyone you've seen present across the years, who would you say was the best? Whose course would you recommend the most? He paused for a moment, searching the depths of his mind. Then he turned to me, looked me in the eye, and said, Diane. And then he nodded, said, yep, Diane. So, you're in for a treat, and I'm confident you'll love hearing the wisdom of a true master over this podcast. So, enjoy the show. Here we go. Welcome to another edition of FC2O with me, Matt Wallden, and my guest today, Diane Lee. Diane, welcome to the show.
Yeah, thanks for the invitation, Matt.
That's a pleasure. Now, Diane, I've obviously been aware of your work, I think like most people in the manual therapy world, for many, many years. I think probably even as an undergraduate, I was aware of your books in the library, and particularly when I was doing my research into my dissertations and theses, then I had to delve deeper into a whole array of different approaches, and your name was one which featured quite prominently whenever I was looking for information relevant to what I was researching. So I've been aware of you since the 1990s, but I think your the first book I saw of yours was the Pelvic Girdle. Was that the first book that you wrote?
No, it wasn't actually. The first book that I ever wrote was together with Mary Walsh, and that was in 1986. And it was a
Right.
workbook of manual therapy techniques, because we were teaching manual therapy methods at that time, and got very tired of people slowing the course down by having to write things down. So we thought that if we
Right.
wrote it down for them and took a few pictures, it would be a good idea. My father-in-law thought
Yeah.
it was a terrible idea, but it was good in the end. But that was my first foray into writing. But you're right. From the first published book, it was in 1989 with Elsevier, and that would be the Pelvic Girdle. Yeah.
Right, right. I see. Okay, fantastic. So then, I think you and I first met around 2003. But let's sort of talk about your career and how you got into physiotherapy, or do you call it physical therapy in
We,
Canada?
we
Physio.
physiotherapy. Yeah.
You do. Yeah, yeah.
Wow.
Okay.
Okay. So I was a competitive gymnast when I was a teenager and a child, and I
Mm,
dislocated my elbow at the age of 16, one of my injuries, and I ended up having physio at the time. And I was in grade 11, and it was a time when everyone was thinking about what are you going to do after school. And my father wanted me to be an English teacher because I could write well. And that was the
mm,
last thing on the planet I wanted to do. I wanted to go for a gap year. But that was in backpack Europe. That was the thing to do in the 1970s. So, but that was totally out of the question. It wasn't going to happen. And so physio seemed a bit interesting, what they were doing with my elbow. So I looked into it at UBC. And
yeah.
what I really liked about it was that there was 800 applications per year and only 30 people got in. So I thought, if I apply for this, I'm not going to get in, and then I get to go travel. Guess what? I got in. I got in.
Ah,
And not being not being one to tell my father a lie, I sort of went along with it. But for the most part, I really didn't like it much.
right.
I didn't find much use in it. But you got to remember what physiotherapy was like in the 70s.
Mm,
I mean, the best thing about being the old dinosaur now is the evolution and change that I've seen in this profession.
mm,
Because what we were doing at that time, we had no anatomy of the spine. We learned nothing about manual therapy. That belonged to the chiropractor or to somebody
right.
else. There was no manual therapy then. This was long before iPhone even existed. And we pounded chests, fitted crutches, walked people,
Right.
mobilized them, gave them exercises. And there was the only hands-on intervention was effleurage, massage, not even specific trigger point stuff. So that was my beginning into physiotherapy. But I really, my good fortune was to meet Cliff Fowler,
Mm,
and to be able to work in his practice and to be mentored by him, John Oldham,
right.
David Lamb, and Earl Petman, who are the founding fathers of manual therapy in Canada.
Right. Fantastic.
1981. Yeah.
Yeah, yeah. And so where did your journey go from there? So did you actually work in the practice with them, or they trained you, or?
I did. I did.
Mm,
I was working at the Workers' Compensation Board. I spent 9 months in general practice in hospital because you couldn't get into private practice. They barely existed in
mm,
BC at the time. I think there was only two, Cliffs and another fellow in North Vancouver. And everybody had to work in a hospital doing a junior rotation before you could even apply. At the only orthopedic place was the Workers' Compensation Board. So after 9 months in the hospital and hating it, I actually got a job at Workers' Comp, and I didn't really like it much there either. Physios didn't seem to do very much other than hot packs and ultrasound. And I started doing the manual therapy courses, which were very, very new in 1977.
right.
And it was at that time that Alan Morgan was looking for somebody to help him in his practice, and he had a split practice with Cliff Fowler. My The day I decided to quit physiotherapy and go back into medical school was the day my husband phoned and said that he'd got accepted into dentistry. So one of us had to keep working.
Oh
And
wow.
so I took this job way out in the boonies in Surrey. It was like a 45-minute drive from where we were living. And
Right.
from the day I started, I was like, roll up your sleeves. Here we go. You know nothing. And it was just the wildest, best year of my career. He taught me how to clinically reason before there was even a word for it, taught me how to
Right.
make sense of findings, taught me to trust my hands, taught me to test the evidence that wasn't very good that was being published in
Mm,
terms of comparing it to what I felt in clinical practice. And yeah, it will be. I mean, I really believe in mentorship. That mentorship is the thing that turns a new grad physiotherapist into a quality clinician versus
mm,
a technician.
yeah.
And that for me in 1981, being part of that whole group that helped to develop the curriculum for Canadian manual therapy was pretty awesome to be part of. And we've grown a lot since those days as well. And some of it, as we'll chat about, is because of the evidence and changings and things, and some of it is just because we didn't follow anyone. We kind of like Canada is in general, we integrated.
Yeah, and that's very obvious from your work, looking at all of the different fields that you've drawn into your work. And I remember reading that Pelvic Girdle book and seeing you had evolutionary anatomy in there, and that you had drawn concepts, late, I think in your maybe third or fourth editions, you were drawing in breathing pattern issues and this kind of thing into your models. And I can see that's obviously just the way your mind works, is to integrate. Okay, so you've gone through your training, you've had this mentorship. Where did you go next?
So I only worked with Cliff for a year, and the fellow whose practice I was taking over, Alan Morgan, he came back to work, and basically there wasn't room in his practice for two of us. And I was essentially let go with about 2 or 3 days notice. That's it, because he was coming back. Wow. So my father was in construction at the time, and Cliff called my dad and said, "How would you like to build your daughter a clinic? There's a small space next to the orthopedic surgeon that refers to us." And so that's what happened. My dad came down to North Delta and took this little 500 square feet and converted it into a 4-room clinic. No exercise space, just all manual therapy rooms, 1 for traction, 3 for manual therapy, small reception area. I was 26 years old, and Cliff said to me, "You're way too young to be doing this. Keep your head down, do good work, and just let your results speak for themselves." And that's what I did. 500 square feet. Practice grew from single practitioner to, I think the most that I've had has been staff of 25. Wow. There's 18 of us now. It's been, the clinic has been in 5 different locations. I've never expanded to more than 1 clinic. I've always wanted to be on site and to mentor within I wasn't interested in a number of different places. I wasn't interested in the big business model. I was interested in education right from the get-go.
Sure.
And so I've had a clinical practice of my own since 1981. Started teaching in the orthopedic division after I became a fellow of the Canadian Academy of Manual Therapy, also in 1981. That was a busy year.
Yes.
And so I started teaching in the courses that were developed by Cliff and Dave and Earl, the guys and gals that were ahead of me.
Yeah.
Became a chief examiner for the system for 20 years, and so was instrumental in developing the Canadian curriculum, which I think in the 80s everywhere in the world was very much based on biomechanics and biomechanical models, and not about things being in and out. That was never a philosophy of physiotherapy. It was just, what's stopping it from moving, and do we have a technique that used our hands that could facilitate that movement? Sure. And the thing that's really changed, Matt, has been understanding the mechanisms that underpin what we do with manual therapy. But And I think the way we touch people has really changed, but the fact that we touch them hasn't.
Yes, for sure. Okay. So then when did you write the first, so I think you said, was it 89, the first edition of the Pelvic Girdle?
So the invitation to write that book came in the early 80s. And it came to Cliff. Yeah. It actually came to Cliff from Gregory Grieve, who some of your listeners will remember from the UK. He was on the board of directors for Churchill Livingston at the time.
Right.
And it was around about the time that Lance Toomey and Nick Bogduck had submitted their proposals to write their first book on clinical anatomy of the lumbar spine.
Right.
And the board of directors at Churchill Livingston had said to Lance and Nick, "Well, what about the pelvis?" And Nick had said he refused to write a book that had anything in it for which there was no evidence. And so Greg said, "Well, wait a minute, I have a friend in Canada who's really into the pelvis. Why don't we invite him to write a book?" So Greg called Cliff. There was no email at the time. There was just a telephone line. So he called Cliff and said, "Want to write a book on the pelvis, Cliff, with all your ideas and things that you've been doing?" And he said to him, "Nope, but Diane will." And I said, "Who are you talking to? And what's this about?" And my husband was in dental school at the time. We didn't have any kids, and I was really practicing in the model that Cliff was using at the time. And I went, "Sure, why not?" So every Saturday, I would head to the Woodward Library at UBC, where all the references were. It took me 4 years, Matt, to go up into the stacks where all the articles were. Go through Index Medicus, first of all, look for the keywords: sacroiliac joint, manual therapy, back pain.
Yes.
Didn't have a term of pelvic girdle pain then.
Yeah.
Climb up to the stacks, get all these journals, stand in front of the photocopy machine with my bag of nickels, throw a nickel in the machine to photocopy a page.
Yeah.
Yeah, and I may get home after 6 hours of work with 6 articles. And you may think that sounds laborious, but it's equally laborious now just to send a search request to the local librarian, and all of a sudden, within one day, you've got like 100 articles to go through. So we're swamped by volume now, as opposed to time poor then. So after 4 years, I went all the way back to 1905, which was when Fryatt was first writing about sacroiliac joint stuff. So I did a lit review from 1905 to 1980, whatever the year was I was writing. And then it took another 3-4 years to get that book, which was state of the art in 1989 and probably should be used as a shoe shim now. But yeah, that was the process. That was the process then.
Wow.
Yeah.
And when did the World Congress on Low Back and Pelvic Pain come into the picture? Because that must have been around that time, was it?
Here's an interesting story. So I'm at work and I get a call. I get a page from my receptionist, basically, who says, "Oh, there's a guy on the phone and his name is Vlaming or something. I can't really understand his accent, but he wants to talk to you about, I don't know, but do you want to take the call?" And I said, "Take a message." So I put Dr. Andre Vlaming on hold, or actually told him I'd call him back. Anyway, when I called him back, this was about 1991, and he was at the time, together with Vert Mooney, organizing the very first interdisciplinary World Congress on Low Back and Pelvic Pain in La Jolla, near San Diego, in the USA, and it would be in 1992. And somebody had put that very first green edition of the Pelvic Girdle book on his desk, and Andre had always had this philosophy that the pelvis was going to be important for back pain. And his supervisors had said to him, "Forget it, Andre. There's no career in the pelvis. Look to the disc. Do everything. The lumbar disc is where you're going to make your career."
Right.
Well, Andre wasn't interested in a career. He was interested in anatomy and connections and function. Which is what the little green book was about.
Yeah.
And so he gave me a call and he asked me if I would be interested in presenting on the relationship between the low back, the pelvis, and the hip. I said, "Sure. How much time do I have?" And he said, 15 minutes. Oh my gosh. So I met Andre in 1992 at the World Congress on Low Back and Pelvic Pain, and we've just had our 10th Congress in Antwerp last month.
Yeah.
And that experience really opened the door for me to really look at manual methods. At that time, Andre was saying, "It's just fiddling, give it up." And so we were at loggerheads right from the beginning in terms of the role of manual therapy in helping people heal from whatever condition they had. We had the opportunity to travel together and to teach in several places in the world in the 90s, and be forever grateful for his mentorship and taking my hand and guiding me into different areas that weren't so biomechanical and more about force closure and form closure and the theories that he developed through his PhD in terms of how the pelvis functions. And then I was invited to the Gold Coast in Australia in 1995 by Gwen Jull to talk about the pelvis. And I was sitting with a row of speakers, and there was this young man sitting next to me, 29 years old, very intent on looking at the paper he was presenting. And he looked at me and he said, "Hi, my name's Paul Hodges." And I went, "Oh, nice to meet you, Paul." And he says, "What are you talking on?" So I told him, and I said, "And you?" And he says, "Tranny." I said, "Pardon me?" "Tranny." I said, "Well, what is tranny?" "Transversus abdominis. Do you know about it?" And I went, "Well, I know it's an abdominal, but that's about all I know." And
Right.
you know where the story goes from
Yeah.
1995 onward, and the
Yeah.
thousands and thousands. This was before he'd even had one paper published.
Oh
So
wow.
I followed Paul Hodge's work for many years, many decades, and he's
Yes.
another mentor of mine who's obviously helped me bring some of the clinical information and evidence we have regarding diastasis rectus abdominis
Right.
to publication. And
Yeah.
yeah, so that was the world of motor control, form closure, force closure, motor control, and
Yeah.
integrating it all with biomechanics. So I'm a
Mm-hmm.
curious learner, as are you, and
Yes.
very open to new things or new ways of explaining things.
Mm.
But what I
Mm.
have never, ever, ever lost faith in since 1981 is my hands, my ability to trust what my hands feel. I may not understand what I'm feeling,
Yeah.
but I do trust them.
Yeah, and I think that's lovely that you have that, because one of the things that you and I have discussed in the past is how sometimes in these kind of more research oriented forums and conferences you can be there amongst a group of people that really are hands off. They're very focused on experimental research, on lab based information, and they're not actually at the coalface working with the patients. And how do you see that as being reconciled in clinical, or for clinicians, let's say, because there's a lot of kind of noise, isn't there, that comes from the world of research, especially with social media these days.
Oh, totally, totally.
Yeah, yeah.
And there's a history and a journey to that as well. In
Mm,
1995 at the World Congress, Dr. Bent Sturesen, who, for those of you who know the evidence around the pelvis, will know that in 2002 he did his PhD looking at the load transfer tests. And one of the
mm,
things that he found is that even in people with pelvic girdle pain, the SI joint doesn't really move that much. And so
mm,
just based on that finding, he made the conclusion that therefore the movement is too small to feel. Meanwhile,
mm.
at the same time, I was presenting passive mobility testing of the SI joint and integrating form and force closure mechanisms and how we can test the articular integrity of the
Yes,
SI joint with form closure tests and how we can test the force closure mechanism with motor control and force closure tests using our hands. And
yes,
after I presented this, he says, I don't understand what you're talking about. The joint is so small, or the joint movement is so small.
mm,
Um, Tell me, show me what you're doing. And I said, well, I can't really do that here, Bent, because you have to take your pants off. And in the foyer of a World Congress, that's probably not appropriate. So why don't you come to my room? And after I said that, he just looked at me, big eyes, and I went, and let's bring a few other people. So I coerced Britt Stuga, who I knew had an asymmetric amount of mobility between the left and right sides of her pelvis. Let's just put it that way.
yes,
And
yeah,
so Britt joined us, and there's a few other people as well. So I'm
mm,
standing on my bed in this hotel room, and all these people are laying on the floor, and I'm
yeah,
teaching them how to feel the arthrokinematic glide at the SI joint. And Britt
mm,
is just one of the patients on the floor. And
mm,
as Bent gets to her pelvis and feels the left and right side, he can clearly feel the difference in amplitude of movement between sides. And
yes,
he looks up
yeah,
at me and he goes, what am I feeling? I said, I don't know, but you're feeling something different between the left and
yeah,
right side, aren't you? And he went, yes. He says,
mm,
you can't teach this in a lecture. You can't teach this with a video. And I
yeah,
sat back and I went, manual therapy is a skill, Bent. You have to train your hands, and it can take 5 to 7 years to
mm,
train the receptors in your hands and your brain and to build the brain maps, although we didn't have that language at that time. Said it can take time to really do this. And if you showed me a video of a hip replacement, do you think that would be enough for me to then go and say, I can now do a hip replacement? I don't think so.
mm,
So we each have a role to play in all of this. Now, that was 1995. In 2001, Barb Hungerford presented her PhD paper, which was looking at the stork test or the single leg standing test, and our ability to feel form and force closure
mm,
and good motor control patterns in that, again, integrating the
mm,
evidence that when you stand on one leg, the sacrum should stay nutated or anteriorly or flexed or whatever we're going to call it. The innominate should be relatively posteriorly rotated, and you shouldn't feel any movement between the sacrum and the innominate when they shift their weight onto one leg and lift the other one. And there's a group of people
mm,
with pelvic girdle pain for whom that doesn't happen, and the innominate rotates anteriorly. Her
mm,
methods were using motion analysis and a very rudimentary sort of icon system. It's much more sophisticated now. with only 15 measure points. And she showed that, in a lot of people, the innominate would anteriorly rotate, which is relative counter-nutation of the sacrum in this task. But her research wasn't accepted by those in the know at the time because they felt the movement was too small for the human hand to feel. So that was in 2001 at the Montreal conference.
Right.
In Antwerp this year, full circle. I walk into the surgical session where Bent Stuyerson is moderating the session, and I got there a little bit late, and he's talking about diagnostics and the diagnosis for who needs surgery and who doesn't for pelvic girdle pain. And up on the slide, he has a list of tests, and one of them is the one-legged standing test, stork test, Gillet test, whatever you're going to call it. And the fellow who's palpating is feeling on the weight-bearing side. And I didn't interrupt his presentation. I didn't want to be controversial, but I did approach him at the gala that night, and I said, Bent, are you using the load transfer test in standing? He said, I am. And I said, can you feel the movement now? And he goes, no, but my physios can, and I can test my physios. So he does intra-articular injection techniques. He sees the strategy change, so he's tested it. At the same conference this year, Jo Abbott, who is a biomechanist from the UK, and she has totally changed the trajectory of her PhD since doing the ISM series with me, and has gone into investigating integrating robotics research, manual therapy. She's done an incredible amount of study looking at why do we have such difficulty with inter and intra-tester reliability. And it comes down to a number of different things. But basically using the Vicon system and several markers all over her body and all over her hands. And she developed some gloves, but now she's tossed the gloves. She is reliable to within 0.0056 degrees of transverse plane rotation of the pelvis. And the test is in the moment. It is not testing over time, because we know pelvic position changes over time. And all her studies are really showing is, can we feel the things we say we can feel with the hand? So there's some huge breakthroughs that are going to start coming through in the next 5 years that help to explain why the methods for studying what we do as manual therapists have failed manual therapists. So her paper was titled, "The Evidence-Based Methodology Has Failed the Evidence-Based Understanding for Intertester Reliabilities." There's so many reasons why we can't treat the human being like a building or a machine. So I'm excited for our future. And I think there will always be therapists who are better at education and training. There will be therapists who are better at manual methods, and the best people will be the ones that can educate, use their hands, use touch to change the nervous system, use touch to change whatever it is we're changing, and also help people to move better, to train better, to get stronger, to be fitter, to eat well, to do all the things we need to do to keep the home we live in, named our body, as healthy and as efficient as we age.
Yeah, for sure. Now, I know you know Serge Grakovetsky very well as well, and for a little period of time, he was flying over to the UK fairly regularly to do events with me as well, and of course, he brought his spinoscope with him, which again was a kind of early iteration of the Vicon system, but specifically for the spine. And I remember reading a book which he actually called The Spinal Engine 2, which I don't think he ever published. But within that, he had talked about how, and he was trying to justify the spinoscope methodology of having these markers, these reflective markers on the skin. And he was saying that even though the markers don't exactly reflect the underlying joint motion, what they do reflect is a composite of the joint motion, the deep fascia, the musculature, the superficial fascia, and the skin, which actually is a kind of more real-world integrated understanding of what's going on in the spine than just trying to assess an isolated joint. And I thought that was quite an interesting point, because that obviously relates very closely to what we're palpating with our hands. We're not just palpating joints, are we?
Absolutely. He was so far ahead of his time. I remember taking weeks to read through the article, The Optimum Spine, that big, thick article that was sort of a Coles Notes version of the spinal engine. Right. And yes, it's one of the hardest things I have in teaching now to convince students to do is to back off with their hands. Like they reach so hard for the bone that they prevent the natural movement from occurring. And I think Jean-Claude Guillemberto's work from France in looking at functional living fascia has really, really helped me be able to teach people that when the bone moves, because it is connected to everything all the way through to the surface of the skin, it will create this tsunami effect through the tissue that you will feel with your hands. But not if you press real hard. So the lighter we are with our touch, the more we actually feel. You don't actually have to be on a bone to feel it move. And I think one of the things that Barb Hungerford showed in her studies in 2004 were that even though measuring movement on the surface of the skin isn't a direct reflection of the amount of movement of joints, it's a reflection of the pattern of movement. So, you actually have to have pins and bones and things and eliminate all the other tissue in order to actually quantify what the joint movement is. But that is so clinically irrelevant. That's the surgeon's realm. We're never, ever going to be using that in clinical practice. So it doesn't translate to clinical practice to even do research like that. But the tool we have is our hands, and knowing and understanding more about how to use our hands, how to surface landmark, whether the thumb should be in the vertical plane, whether the thumb should be in the horizontal plane. What's the best way to place your hand in order to set it up to be able to feel the relative motions. So there's lots of things coming soon that will make that sentence be much more clear.
Okay, good. Now, earlier you mentioned when you're talking about Andre Vleeming, you alluded to the fact that he didn't think that the path you were going down was the right path. And could you elaborate on that a little bit?
Sure. We were the first. Somewhere, the cobwebs, Matt, hang on. This is back in the late 80s, early 90s. It'll be the early 90s, 92 to 95. We were traveling together. And he really felt that manual therapy, his words to me were, manual therapy is fiddling. Give it up. Manohar Punjabi had just published his paper with, the balls in the bowl, the two balls in the bowl, one sort of showing stiff joints, one showing sort of a loose joint. So you got an open flat bowl in the ball and it can roll further. And this was all talking about zones of motion. So the neutral zone, if you take two people and you're assessing the same joint, so it's not a different joint, but say two thumbs, two metacarpal phalangeal joints, and you move one thumb, you glide it dorsally and ventrally, that there can be two very different feelings in terms of the amplitude of the neutral zone. How big is the amount of slide or glide you can move the proximal phalanx relative to the metacarpal before you hit resistance, R1 in Maitland's terms, or your beginning feel in Cyriac's terms, whatever you're going to call it. This whole neutral zone, elastic zone thing. And so I was trying to explain to Andre, we were in Billund, Denmark at the time, about to present at a conference. And we'd gotten there a couple of days early. Both of us had gotten our dates wrong. So we had a couple of days to kill. And only thing I could think of was to use Punjabi's model of balls in the bowl to describe to Andre what I feel in my hands when a joint is compressed by muscles that may be overactive. I don't know if that's the right term to use, but muscles that are driven by the nervous system, where they're being told to contract too much by the nervous system, that situation. That feel in my hand is very different than a joint that has been sprained and perhaps has more thickening around the capsule or tissue that's not as hydrated. And in the old days, we would have called that a stiff fibrotic joint. So those two joint feels are very different versus a joint which has lost the ligamentous integrity, like an ACL injury, a complete avulsion of the ACL, and what that would feel like. So we started drawing all these different shapes of balls and bowls to explain what the hands were feeling. And as part of this Congress, we had there's 250 people there, and we had a short practical session at the very end, and there was only 40 people in the practical session. But this is where I actually taught the passive mobility test for the sacroiliac joint, and there must have been an uneven number because Andre became a patient for some reason, and somebody did it on him, and he could actually feel it because our interoception in our body, if we bring our awareness to it, he's an extremely aware guy, is good, and he could actually feel the difference when I was saying, okay, now contract your pelvic floor, see what that feels like, arch your back, see what that feels like. I was going through the form of force closure mechanisms, showing how different strategies could compress and therefore stabilize the SI joint.
Sure.
And he actually got it. He actually could feel it in his own body, and then he wanted to learn it in his hands. And now he's been sort of teaching it for 30 years. He doesn't understand it. I don't think any of us do completely understand how manual methods work, but those of us who use our hands in practice as well as everything else are fairly certain they do. We just don't know how to explain it and help develop good research studies that actually duplicate or replicate what it is that we do in the clinic. Because, I'm sure you've had this experience as well. You can be on a course and you can have two different practitioners doing so-called the same technique on your shoulder. And one of them, you want to say, oh, keep going. That feels lovely. You can feel things soften and open up. And somebody else who is doing technically exactly the same things, but it hurts, you're bracing, you're getting defensive, and you just want to tell them to take a hike. So it's the way we touch, it's the amount of force, it's the softness, it's who you are in your interaction with the person. I mean, I think Bialowski and his whole model of the different components in terms of touch is so relevant to what we do. In terms of manual intervention. It's not just about the technique, right? It's not just about the technique.
Yeah, absolutely. Yeah. One of our wise old owls at the osteopathic college always used to say, this is a guy called Mr. Kiley. I don't know if you've ever met Dennis Kiley, but he I think was the dean of the British College of Osteopathic Medicine for many years, and he used to say you have to love the body, and he would show, perhaps a mobilization technique of the thoracic spine, but he'd just get in really close and make the person feel supported, and he was soft in his touch, but he was strong, and he was an amazing technician, but had that kind of connection, which is what he was trying to convey by saying you have to love the body, so I think you're absolutely right. The touch and the way you interact is so important.
Two words you said there that I so resonate with: soft but strong. So the patient always is in control. Now, this is different than a manipulation technique, but for like a high velocity, low amplitude thrust, but which has its place as well, but I don't use those techniques as much as I used to. But the soft but strong, this is where we're going. I think we have the biggest opportunity to change pain, change sensory input into the brain, change our somatoperceptions so that you can start to reorganize the mental body map, if you like it, to be able to discriminate between safe movements and threatening movements, to provide the safe stimuli and to be able to have the person move while you're facilitating movement, kind of like a mulligan thing, like mobilization with movement, that sort of stuff, where you can, if you change the person's experience of their body and the sensory input from an area that normally hurts, and you provide a different sensory input from an area of the body that normally hurts. For me, that is so changing, so empowering for the person to then absolutely start to take back control and to start to want to have those experiences with their body when they move in that way again. And I can do this. I can explain this much better with my hands than I can with my left brain and language.
Yes. And I guess it's also one of the things that I find very interesting when you see these kinds of debates emerging around what's the right thing to do and what's the right technique or the right approach for a given situation, is that quite frequently it doesn't seem like there's the kind of clinical experience behind the arguments. And what I mean by that is that some of the techniques that I learned from you in the early 2000s. So, for example, form closure, essentially mimicking the transversus abdominis function with the active straight leg raise test. That assessment. I remember having a a basketballer come in, and this was one of those situations where I'd organised a meeting, and had said to these they were mainly Czech trained professionals, but I said to them, look, if you've got any clients that you want to bring in and we can do a sort of live case study, then we'll do that. And so you're on the spot, you're there at the front, and I know you do this as a living, so you're used to this. This was quite novel for me at the time. And this guy brought in this elite basketballer who's in the England basketball team. I suppose that doesn't necessarily make him elite, but you know what we're like at basketball in England. But anyway, he's national or international level, and he had this recurrent hamstring strain. And so it must have been after 2003, because I'd read Barbara Hungerford's paper, who you mentioned earlier, about how the biceps femoris will increase its tone when there's sacroiliac joint pain, and the transverse abdominis seems to decrease its tone or decrease its firing, or delay its firing. So I was aware of that. And I remember looking at his low back, and his low back had striations, and you're kind of thinking that looks like what we might call a multifidus inhibition or some kind of segmental instability. I don't know if that's still politically correct or accurate, but nevertheless, there was these indicators there that maybe there's something going on in that deep multifidus area in the lumbosacral region on the same side as his hamstring injury. So, I did the active straight leg raise with the reinforcement of transverse abdominis, and he got his leg up to about 45 degrees, and he's holding his hamstring going, oh, that's it, I can feel the strain in my hamstring. I thought, well, okay, that's, it was quite acute, and obviously quite a low level of hip flexion. He was only, like I say, 45 degrees, and he's feeling the pain in his hamstring. So then I reinforced the multifidus, and suddenly he could lift his leg right the way up to, nearly 90 degrees, and his pain had gone. And he just looked at me like I was some kind of magician, as if to say, like, what have you just done? Like his pain had magically gone away, almost like you've
not
magically unstrained his hamstring. Yeah.
Not a hamstring strain.
That's it.
You just found a pelvic driver.
There you go. But then you have people, of course, I've seen it a lot on the forums just recently, who say, there's a paper even called The Myth of Core Stability, which okay, it maybe isn't quite driving at motor control approaches in the way that you practice them, but nevertheless, there are people that are very dismissive of this kind of approach. But when you're working with clients and seeing those kinds of things happening the whole time, then even if the theory behind it is wrong, there's obviously clearly clinical value to it.
Well, that's what I keep hanging my hat on. And I've been interested in the thorax for decades. And it's a very difficult region to research, because we don't have yet, Joe Abbott's working on it, we don't yet have a machine on the planet that can measure movement between like a 6th and 7th rib, so between two rings. So if we consider one thoracic ring, so 2 vertebrae and its ribs and all its attachments all the way around, you essentially have 10 pelvises stacked on top of one another, right? And we don't have a machine that yet can measure what's happening between the two now, or let alone within a ring. Now, there's those who will say, well, why do you have to? That's too biomechanical. But in 1996, when I published a paper in a journal on what I called at the time a lateral shift lesion, all bad language now, I know, that was 96, forgive me, but I picked up that there was people who had trauma to their thorax, a seatbelt injury or a direct blow, who couldn't rotate very far at all. And it had seemed to me that there was this one ring, one segment that was held in a rotated position with a contralateral translation. When I would do a high velocity, low amplitude manip technique on that, their rotation was restored completely. And that was in 96. And then in 2003, so Linda Joy Lee joined me in 1999 at the clinic, and she started to assist on some courses. It became very clear very early on that very, very bright clinician, bright gal, lots of innovative ideas. And in 2003, she actually showed me something that she'd figured out, which is this thing called a thoracic ring correction, that you could actually do something with your hands that changed the movement pattern, change the ability of this person to move immediately. And I mean, it blew me away when she showed me that in 2003. And we've went on to develop this whole thing called the integrated systems model, which isn't just about the thorax, but the power of it is that, and the touch is really light, that you can touch somebody that lightly. And now I call it working in the nervous system, and evoke a change with that sensory input, evoke a change in the motor output to the point where you can increase someone's range of motion 40, 50 degrees. Now, this is just a test. It's not treatment. It's diagnostic. But it certainly, just like your active straight leg raise test, rules out that the joint is stuck, stiff, or that there's anything biomechanical about that if we define biomechanics as only being joints. For me, biomechanics is about everything. Biomechanics is about posture, movement, motor control. It's the one word that describes it all. But the thorax, if in that same guy that had hamstring pain, posterior thigh pain, poor pelvic control, if you had supported his pelvis, so did a compression of his pelvis like the active straight leg raise, there's a subgroup of people where that wouldn't have improved. Now, would you have then gone on and treated his hamstring? No, because you could have exactly the same thing happen by taking the twist out of his thorax. You could take the twist out of his thorax, and that can change the motor control strategy to the pelvis, stabilize the platform indirectly, and his leg would have popped up. So we started with Jan Men's test on the active straight leg raise in 1995. And I remember Andre calling me and saying, we've got the gold standard test now for, and we were calling it pelvic stability at the time. We don't now, but we call it control. But in the time it was called pelvic stability. And it was the ALSR test, and just generically compress the pelvis. And if the leg flies up, then the pelvis is unstable. Train them. And I said, oh, leave it with me for a while. That seems too simple, because when you treat complex patients like you and I do, we know that nothing is ever as simple as what they have to reduce it down to study it and research.
That's it.
So I started playing around with locations of compression. Compress the pelvis in the front, compress it in the back, compress one side in the front, one side in the back. And this is what led to the development of the compressor belt, and now the more modern, the baby belly pelvic support, where the straps, you can vary the location of compression. Now, it doesn't mean that if you bring the straps to the front, that transversus is weak, or if you bring it to the back, that multifid is weak, because it's about force vectors, and you just have to assess the motor control to understand what the deficits are. But the patients,
so just to explain the strap a bit better to the listeners, so you know, you describe it, because I know roughly how it looks, but you have a better
so it's a belt that's quite different from the Sorolla. In the Sorolla belt, the straps are attached over the back of the sacrum, and then you pull from there and attach to the sides of the innominate. On the compressor belt or the baby belly belt, the straps, the compressing straps, so you have this elastic belt that wraps around you, number one, just a very general compressive strap, and then a second set of straps that are sewed in the mid-axillary line. So they're sewn just in the plane or the line of the greater trochanter. And then you can take these straps and either attach them to the front of your pelvis for more anterior compression. You can attach them to the back over the sacrum for posterior compression. And we used to think at the time that it would do what multifidus should do what transversus should do. But clinically, it didn't pan out. It wasn't like that. Because you could have too much, it's all about force vectors is basically what it's about. But there's also a group of people with pelvic girdle pain that when you compress their pelvis, it hurts more. And their task, whatever it is, whether it's an active straight raise or squat or single leg standing test, gets worse. That tells you that further treatment of the pelvis in terms of training or motor control training is not going to work. You're not working on the place in the body where you're going to get your biggest change. So in the integrated systems model, we call it finding the driver, which is basically the region of the body which is the best place to start to intervene, at least with manual methods anyway.
And do you, I know this is probably the material of the courses that you run, but do you have any kind of model as to how to prioritize assessment of the body, or is it a case of going through each kind of key area one by one?
So It is.
So if we were to take the hamstring example.
Yeah, it is. So let's say you have an elite level athlete, basketball player, football player, whatever, elite level athlete who has chronic recurrent hamstring pain. First thing that comes to my mind is exactly Barb Hungerford's research. They're overusing their biceps femoris or their medial hamstring, whichever one that is that's the problem. Then the next question becomes why. So for me, I follow Andre's philosophy of that the pelvis is a platform to which attaches 3 levers, and I would always start at the center of the body. Do they have pelvic control? Can they control the joints of the pelvis? Yes, no. And then if they have loss of pelvic control, overactivation of biceps, I want to know why. Is it the old ankle sprain that is causing excessive internal rotation of the hip, to which is mucking up the motor control strategy, at which point you're looking up and down the body the whole time for the task. So you would pick a task. So you'd ask the guy, so when does your hamstring hurt? Well, when I go to do a jump, a single leg, show me how you jump. And so you watch them jump, and often they'll take off on 1 or 2 legs. And then you assess the entire body visually to look for where does it look like there's suboptimal alignment, biomechanics, or control for this task. And we actually divide the body into functional units. So the first functional unit is the trunk. So we're looking at about rings up to about the 3rd ring, so just around the axilla area down to the hips. We look for things that are suboptimal in that area. And I know some of your listeners are going to think this language is dangerous. It really isn't when you watch us work like this. We're looking for really significant things that are fairly obvious, not little tiny things. And then just because the person has a finding, it doesn't mean that it's relevant. You then have to test it. So if they've got a loss of pelvic control when they stand on one leg, then I'm going to give them pelvic control. So I'm literally going to compress the pelvis and then ask, better, worse, no change. Oh, no, my hamstring's still killing me. Meanwhile, they've collapsed on their foot. Their heel has gone into eversion. Their foot's flattened. And you go, all right, so let's see what's happening with the foot. So you go down to the foot. You stack the hind foot. You hold it there. You palpate the SI joint with your other hand. You have them shift their weight onto that side. And they go, oh, my hamstring doesn't hurt as much. And you go, oh, and guess what? When you have your foot right under your body, your SI joint doesn't unlock or doesn't give way. And we could spend hours debating the mechanism of that. But to be honest with you, Matt, that's for research. I don't care. I just know that if I fix this foot and if I get this foot functioning better, I'm going to change the strategy that he's using to stabilize his pelvis. That would be called a foot driver. And so on and so on. So you go to the different regions or areas of the body quickly. So within 10 minutes, I want to know, can I change pelvic control by changing somewhere else? Where do I have to go to change the motor control strategy for pelvic control? And if no correction anywhere changes the pelvic control, then I have to go to the pelvis. Because that, for me, if the pelvis isn't able to transfer load, you can't sit, you can't stand, it's difficult to sleep, it mucks up everything.
Yes. Yeah, for sure. Okay, so now I know we've talked a bit about motor control, but and also a little bit about you mentioned manipulation earlier, and I remember a conversation that you and I had quite early in the 2000s, and I think I was asking you about motor control and made some kind of comment that was a little bit negative, perhaps, about spinal manipulation, saying perhaps spinal manipulation isn't the answer to all low back pain or something like that. And you wrote back to say, well, actually, it does something, and we don't know what it does yet. And I just thought that was fascinating. And you've done some training with Laurie Hartman, I believe, at various points. And So now, where does, because I obviously quite a few of my listeners are osteopaths, as in British osteopaths, and the sort of more manual therapy oriented osteopaths. So where would you see manipulation and or other mobilization techniques fitting into the work that you do?
I'm not sure if you've seen the article by Giles Geyer, Jimmy Michael James Inkelbarger, the spinal manipulation therapy. Is it all about the brain? It's a current review of the neurophysiological effects of manipulations. What I was reading this morning, getting ready for just waiting for your podcast. Okay. And it's it really is a good article that kind of summarizes again historically what we've thought in terms of the mechanisms of spinal manipulation. So we used to have in days gone by these theories that biomechanically what manipulation could do, it could release trapped synovial folds or meniscoids, it could restore so-called buckled movement segments, could reduce adhesions, or it could have a reflex effect of normalizing overactive muscles. And this was sort of kind of the four basic sort of premises in terms of how spinal manipulation works. And I think for the spine, I think the main mechanism theory that's getting explored a lot is the neurophysiological one. The effects that a high velocity, low amplitude impulse to the skin, to the fascia, to the joints, to the fat, to whatever receptor is going to receive this impulse. The influence that this has in the nervous system. I think this is the mechanism or the explanation that's really getting investigated a lot. But the thing, Matt, every time I think that spinal manipulation is, and I don't want to minimize this and say merely neurophysiological, because it's a pretty powerful neurophysiological tool and opens up the nervous system for different ways to move, allows the body to move differently. So when we couple that release technique with movement and motor control and movement training, and you put the two together, it's pretty powerful. Somebody will come into the clinic that week with an entrapped meniscoid. Like, if you've ever seen one, there is just no denying that there's something in a very arthritic back that has lots of degenerative changes in the zygapophyseal joint. So this is going to be really bad language, but I have no other way to explain it. Something gets stuck, and you can do all the general Chicago $1 million roll techniques that you want with that person, but unless you are precise, specific, and you can distract and gap that joint, nothing will change. But if you can, and you can gap that joint, and there's a horrendous clunk that's way different than a cavitation of a healthy joint. It's just a way different sound. They stand up, their shift is gone, they're straight, they're sore, and now they need their multifidus trained often because it's been inhibited by this pain. Yes, but you don't see these people in the research, because I see like about one of them a year. And they're just not around to be able to take a group of 40 or 50 people with locked backs or necks or whatever we want to call them. But talk to any clinician that's been in practice for 40 years, and they'll tell you that once in a while they run into something in their practice where, man, it sure looks like something's stuck. But that's not the most common thing we see, but I want to throw that out there because I really do think the condition exists. It's just not common. And more commonly, what we see is the motor patterns, the committed motor patterns that we can use high velocity techniques to reset, to change, to create a relaxation response, to create a change in the motor output. And it will only be temporary. Often it's only temporary if the person continues to go back and use their body as they normally have. So unless we bring awareness to possible reasons why or how this is happening repeatedly for them, and have them strengthen and train or train in a different way, often it becomes recurrent. I think we all still have those people in our practice that have been manipulated repeatedly. And we're all guilty of doing this at some point. They come back and they just, I just want you to crack my back. My back is out. I want you to crack it. And the hard thing to crack is the belief that, you know what, we don't do that anymore. We don't. But it's some of it's about patient expectation, and they get better, but you're feeding into it. And I'm always in this dilemma when it happens. I'll do anything but manipulate that back to try and make a change, just to treat their cognitive belief. And
that's it. Yeah, for sure.
You're trying to treat, they're hard, especially when you've been guilty over 30 years of feeding into it. And anyone who says they haven't isn't telling you the truth, because we all grow, we all learn, and been there, done that. I can remember in the 1980s, early 80s, after treating somebody, probably with a manipulation technique, this person saying to me, "Are there any exercises that I could do for this?" And honestly saying to them, "None that I could think of." And now you could give them a list as long as your arm, right?
That's it. Yeah, for sure. Well, leading on from that, the preventative side of physical therapy, I think, is something that's a little bit understated and perhaps, or let's say historically, of course, the reason a patient comes to see us is generally because they're in pain or they're dysfunction, for want of a better term, for perhaps something's clicking, something doesn't feel right to them, however they want to express it. And it's because that thing has become persistent and hasn't gone of its own accord that they tend to seek out someone like you or me. But do you think we have a role more so in prevention, that it's a kind of, it feels to me like it could be more of a fertile field than just
Absolutely.
reactive stuff?
Absolutely. And the problem is, how do we language it and not create practitioner dependency? So we have, I think that the dentists have created a fantastic model. The chiropractors have tried to, but then they've been accused of just having people come back and creating practitioner dependency. So there's the extremes there. How come
Yes.
it works for dentistry, but it hasn't worked so well for chiropractic? And in physiotherapy, we tend to say, when the patient says to you, should I come back in 3 or 4 months? We'll see how it goes. And if you're having any trouble, come see me. So again, we're relying on pain and dysfunction as the indicator as to when you should come back, which is not right. Like, if we want to help people who are really active stay well in their body, the question is, can we pick up relevant impairments before there is a danger signal? And I think we can. But in order to do this, we have to rely on some understanding of how we think that person should be moving. And I know that this is fraught on social media and in the research, with people saying, well, it doesn't matter how you move, doesn't matter how you sit, just move, just do anything. And it's about determining the relevance. And that's the tricky bit. So if you bring somebody back and 3-4 months after you've seen them for back pain or whatever, and you look at them and you go, how are you doing? And you're saying, oh no, things are going well, I'm doing everything. And there's no meaningful task. There's nothing that you can evaluate, because they not having difficulty with anything. Now we're becoming judgers. Now we're starting to look at someone's posture, how they're moving, and we're judging that this may not be ideal for them. And sometimes, unless it's really obviously bad, like you're bending your finger backwards and sitting on it, nobody would ever think that that's a good thing to do.
Yes.
I use an extreme, because we can't just talk about anterior pelvic sway or S postures anymore, because there's people that are highly functioning that have that kind of posture. We have to. It's an area I would love to get into, but it's an area that's going to be fraught with, well, how relevant is this finding? Like when I teach, one of the biggest things I really try to instill in the students is, just because you have 6 or 7 things that you find doesn't mean that any of them are relevant. You have to test the relevance of that finding to the task and the patient's experience in that task. You have to change the nervous system. You have to change how they're perceiving their body. And it has to be related to that task if the finding is going to be relevant. Otherwise, we're making decisions that are you're just catastrophizing the whole situation. So in prevention, I think there's some things I think that are an absolute must. You must have pelvic control. If you don't have good pelvic control during your task, it just makes sense to me that something's going to go awry. So it would be one of the tests that I would look for. We have gotten involved with the Manchester Football Club a number of years ago, LJ and I, when they got some funding to do some screening of their players every 6 weeks. So they adopted the integrated systems model and did some screening for their players. And whether it was coincident or not, who knows? But they won the Premier League that year, and they had the lowest number of players lost to injury in the season. So they were at the top of the Eeks Grand store, or whatever that thing is called. They did really, really well. They did really well.
Yeah.
And that was when the therapist introduced whole body screening. So I think it's done it's done in the Cirque for sure. I know that. So Cirque du Soleil's in town, and I'm doing some consults for them coming up. So for some of them, it's prevention. So for dance companies, sports teams, they're certainly on it, but it hasn't extended to the general public. And part of it is because we don't have a good way of knowing what's healthy movement, what's healthy sitting, what's optimal, what should we be doing. I think it's a good idea. I'd love to be involved with it. I
Yes,
have
yes.
people coming back in the clinic, and I just cross my fingers and my toes and sort of hope that things that I'm finding are relevant and that they stay healthy and that I'm not wasting their time and money by doing it. But I'm cognizant of the conversation in the back that
Mm,
says posture doesn't matter. So for me, I really think it does.
mm,
But there's extremes,
mm.
right? There's subtle ones that don't.
Yeah, yeah. Well, one of the things that I've experienced having been involved in the check system as I have, it kind of straddles those two worlds of clinical work and rehabilitation, but also the kind of strength conditioning, personal training worlds. And of course, a lot of what the personal training world is doing is preventative, and it's building people's health, it's building their strength, and it's building their resilience, and so on. And at the higher ends of that world, I think there's a lot of potential carryover with what we're doing, and almost the preventative side is partly built into that already. And I was going to link it in a bit with your model, the integrated systems model. You have respiration within that model, don't you?
Absolutely.
Yeah. And I don't know, because I haven't looked at it recently, but did you ever, I know I've heard you talk about nutrition as well, but obviously, again, linking back to the personal trainers, that's part of their world is the sort of, it's wellness, it's health, it's sleep, it's hydration, it's nutrition, and it's movement. And so these are a lot of things that are, we assume, and some of the research suggests that are preventative in musculoskeletal pain. So
more than that, they're restorative, Matt. Sorry, did I cut you off? Keep going. Yeah.
Well, no, that's fine.
Because
We've got a bit of a delay.
yeah, exactly. So physiotherapists are typically not trained in nutrition or in gut health. And yet I don't think we can deny the emerging evidence that gut health and the fact that 2/3 of our immune system lines the gut and its role in inflammation, the role that plays in core control. So if you ever see someone who has irritable bowel or just even gut sensitivities, one of the things that they'll say is, I'm bloated. Well,
Yeah.
the bloating is in part, sure, swelling of the organs, but it's the inhibition of the abdominal wall as well, because
Exactly,
it
yeah.
hurts. It hurts to use it. So there's a direct relationship there between visceral health and visceral health of all sorts, whether we're talking endometriosis or cystitis or chronic, kidney pain, kidney stones, stomach, ulcers, pancreatitis, all of those things.
Yes.
Visceral health is intimately related to musculoskeletal health, not only anatomically, because the fact the organs hang off our skeleton, but the viscerosomatic and somatovisceral reflexes through the nervous system, and also just because of pain responses. And in the people that we see that are often diagnosed with fibromyalgia or polymyalgia or multiple muscle pain syndromes, a lot of these people come in and they've got a Diet Coke in their purse and they're chewing sugar-free, they're eating aspartame, and they have no clue that what they're feeding themselves may be contributing to their headaches, bladder cystitis, back pain, the complex person with multiple comorbidities that are excluded from all trials because they're too complicated. These people, often I will start with gut health, but I'm not the person to supervise that. I share with them a lecture I have from the anti-aging conference in Las Vegas, which is called Food and Pain, and it's a series of speakers talking on the relationship between food and pain. It's a 45-minute lecture, and I say, if this resonates for you, then here's a number of people that you can go see that will really help to get your gut health in better order. And then let's see what the relationship is between some of your MSK symptoms and how you're able to move and your gut health. I think it's a huge player and part of it. And something that physiotherapists are not adequately trained in terms of their formal training. If they have training in it, like Jessica Drummond, she's amazing in the United States on all things gut, but she's got that training after her graduation. So it's been a special interest of hers.
Yeah.
It's
Well,
so
one of the papers that I've been aware of is that there was a paper that I quoted in one of my editorials, which was a guy called Aspero, and I think his co-worker was Malagalada or something like that. And it was a paper from 2005, 2006, and it was on IBS. And what they had done was they had taken X-rays of the gas surface area in IBS patients, with the assumption that, of course, if your waistband increases by, in some cases as much as 100%. I mean, you can get a big, you can go from 24-inch waist to 45-inch waist, like it's properly bloated, huge sort of expansion of the abdominal wall. And what they found was that the gas surface area across, I forget how big the group was that they assessed, but across the experimental group, they found gas only accounted for 18% of that enlargement. 1/8, So the other 82%, is essentially inhibition of the abdominal wall. So that's the only other thing really that can explain it. So yes, it does make sense that these conditions would potentially have a direct effect on the motor control. Because one of the things that I've understood from Paul Hodges' work, and I'd love to ask him more about this, and perhaps you would have further insights as well, is that pain seems to inhibit more the tonic drives as opposed to the phasic drives, and tonic motor neurons, and of course, when we're talking about pain, we're normally referring to somatic pain, pain from a joint, pain from a muscle tear, that kind of thing. But visceral pain can do the same, it would seem, through this example of the irritable bowel syndrome and the inhibition to the abdominal wall musculature.
Absolutely.
And of course, it's the tonic system that's so important.
I don't think it's been studied. I really don't. I don't know for sure. But at the last IPPS meeting, International Pelvic Pain Society meeting, which is more about cystitis and vulvodynia and pelvic organ sort of pain as opposed to pelvic girdle pain. It's a multidisciplinary conference as well, an excellent one. And the common feeling was that a lot of these conditions are not about the organ itself. It's about that the representation in the brain is misinterpreting the signal as being from the organ, when in fact the underlying mechanism between all of this is inflammation. And that the main source of inflammation that's coming from is the gut. And the way forward is to restore the gut health. So it's certainly a big player. It's all integrated, right? It's all integrated and interesting. And we can't have the tools to fix every single thing that comes in our office, but we have to be able to recognize the things that we have tools for and the things when we need to refer out.
And when you take that evolutionary view of human function, then what if you go back into kind of deep time, as it were, then you see that the earliest organisms were essentially a gut tube surrounded by musculature. So we talk about the worms, and even anemones and things like this. There's different body plans. So you got the anemone body plan, which is the sort of earliest of the body plans. And you move into the flatworms and then the roundworms, and then essentially our body plan, which is the same body plan as fish. But they all have the same feature, that the gut tube has a muscular wall. And then we just have an extra layer of musculature around that. But it kind of makes sense that if the gut wall is inflamed, then it's going to affect the musculature of the body wall as well, because you don't want to compress something that's inflamed, right?
Exactly. So I don't know how an RCT is ever going to be able to investigate or test the all of the mechanisms at play that we have to consider clinically when looking at the complex patient with persistent pain. So until we actually see a different way, and I think it's going to be a mixed methods research, sort of you having both, qualitative and quantitative methods of some sort. Or I would love to see us get back to the N of one, the single case report and discussions of the single case report. Man, I miss those so much. I don't recognize my patients in the RCT, but I certainly recognize them in the 90s and the 80s when single case reports were being published. Because it's what we're treating. We're treating an individual. We're not treating a group. And it may be a suitable model for pharmaceuticals, but I think it really has failed moving evidence-based practice for treatment forward. We can bench research for individual things that we see in response to pain. And the other thing, Matt, why are we still starting the inclusion criteria for anything with pain? If we look at the pain research, we know that pain, persistent pain, I'm not talking acute conditions now, but persistent pain is an output. It's an impression of the brain. Then why are we trying to find a functional or an intervention that relates to movement, posture, whatever, and seeing if it's going to change pain? That'll never work. So to heck with the pain in terms of the inclusion criteria, but let's go to assess function. The reason it's been stopped is because we've had difficulty getting intertester reliability for the tests that we use to determine function. This is the ground point where things have to change. When we're just starting. So I've been working with Joe Abbott for the last few years in terms of testing ways of all the things that I see when I teach as to why people are not reliable. And moving forward, if we can start to get more tests that are reliable, sensitive and specific, then we can start to develop some research trials around function, regardless of location of pain, regardless of the behavior of pain, because we know all of that is merely an output. But start to look at, if we improve function, if we can improve how well somebody moves, how strong they are, how efficient they are with their movements, will this change the pain pattern? So we're close. We're close. We are up, but close in research means like 10 years. But that's where we're at. It's exciting. It's an exciting time to be a manual therapist. I'm not depressed about where we are at all. I think that it's good to be criticized. It's good to reflect and to be challenged. Not in a personal way, as where some of these social media trolls do. I mean, some of the bad language they use and some of the rest of it isn't helpful at all. But to really be critically challenged and to look at what you're doing. It doesn't mean that what you're doing is wrong, but perhaps how you're explaining it can be a bit different. And I think that things have changed over 40 years for sure, in terms of we are not just a single modal anymore. We're not just training or doing exercise, or we are not just doing thermal modulation, with machines. We are not just doing manual therapy. Things are definitely integrated, which is fantastic. But our mechanisms and understanding how and why these things work has really changed over time.
And that's, like you say, that's great, isn't it? Because it's opening up so many new fields and new paradigms even to explore. I think it's, like you say, very exciting. Now you mentioned, because obviously you've just come back from was it Antwerp, the World Congress? Was that? And you were saying that there was discussion of targeted interventions for individualized care, which is obviously what you're just alluding to there. But this is something that's being actively pursued now?
Not enough. So a lot of the keynotes, so Paul Hodges, Linda Van Dillen, Carla Stecco, a lot of these guys are really talking about targeted interventions that, and same with the McKinsey group. They've been doing it for a while. And I think the reasons why the McKinsey group has got such solid research backing their approach is that right from the get-go, it wasn't based on, okay, you've got back pain, let's extend you. It was always a directional preference, right? There was always a functional thing that they tested. So they've been subgrouping and classifying people ever since they started. So the McKinsey method has always been subgrouping and classifying things right from the get-go. So now we're starting to see the leading researchers in the world in motor control and back pain starting to talk about how important it is to target interventions, et cetera, et cetera. So what we still heard a lot of at Antwerp was non-targeted research. And it drove me crazy because at the end of the day, the non-targeted research comes out with no statistical difference. So I'll give you one example. One person presented a paper, people who had lumbopelvic pain, inclusion criteria were lumbopelvic pain, a slow timed up and go, and difficulty standing on one leg. These 60 people were allocated to 3 different groups. That was all the assessment was, 3 different groups. One was given training for transversus and multifidus, and that was called the core stability group. Second group were given just general exercises, like plank and sit-ups and those sorts of
Okay.
things. And the other group was just given general advice: be active, go do whatever it is that you want to do. No statistical difference in any of these groups at the end of the day, measured on oswestry and quality of life scales at some pertinent time. And therefore, the conclusion is that core stability exercises don't work for lumbopelvic pain. I mean, how ridiculous. I went running down to the mic and basically said, look, all week we've heard about targeted interventions. Where in the inclusion criteria in terms of differentiating the groups of people were put in, did you even identify that there was a deficit of transversus or multifidus in the people who were given that training? Because if there's no deficit, there's going to be no difference whether you train them or not. We are so much further ahead than some of the research that was presented. So a lot of it was really good. A lot of it was interesting. It was good, but the clinical piece is really lacking for me. Not being able to see clinicians work. So
I mean, it reminds me a little bit of there was a paper. I was in one of these discussions talking about posture and how it's seemingly irrelevant in some circles, and I said, well, can you provide some papers? And someone provided this meta-analysis. In fact, several people pointed to this one meta-analysis, and if I recall, they'd gone from about 10,000 papers looking at sagittal spinal curves and the relation to low back pain. They'd whittled it down to the best, highest quality 52 papers, and then the conclusion, when you read the abstract or the conclusion of the paper, was that essentially there was no statistical significance or association with posture and low back pain. And you're looking at it, but they're saying they're just using low back pain as a heterogeneous. It's a heterogeneous issue, but they're labeling it as a homogeneous problem. And of course, when you actually dig down into the papers that they analysed, then when there were two papers in there that related specifically to disc injured patients, and of course we do know that disc injured patients will vary depending on where the disc bulge is and all kinds of other factors. But both of those, they found that those groups had flatter lumbar spines, right? Which is kind of what you might expect for a disc pain group. And then the others were essentially, just low back pain. But to conclude at the end of that therefore low back pain, is not can't be correlated with posture was a very sort of, to me, it seemed a very kind of amateurish finding, and it might be me misunderstanding it, but it didn't really instill confidence in me that this was kind of the key paper that was being pointed to, and it just strikes me that kind of broad brushstrokes approach, as you say, and the meta-analysis kind of approach, it has many issues associated with it. And if we put too much value into that and ignore our clinical experiences and other biomechanical and physics-based rationale, then we could come a little bit unstuck.
Couldn't agree more. And I don't think Sakic ever intended that evidence-based practice be solely based on research. There's always three components to the model. You're evidence informed, pay attention to the evidence. How does it relate to your clinical experience, and how does that match the patient's values and goals? Was always what it was about. And it's a little on a hand, but the pendulum's swinging back. The pendulum is swinging back. And I think that while there's several things we can grump about, we're starting to see more clinicians be able to work with researchers, and instead of sitting in isolation and complaining about researchers doing and researchers complaining what clinicians are doing and saying, that, the time has come to sort of facilitate the working together. And I think that's, I've so enjoyed working with Paul Hodges. I've so enjoyed having the opportunity to work with Joe Abbott and to see the challenges that they have in research. It's easy for us to sit as in clinicians and say, well, why don't you just do this? And it's harder. It's harder than we as clinicians imagine, sort of setting up good trials. But I agree with you that the way we are investigating the kind of complex work that you and I are doing with complex patients with persistent pain, it's certainly not serving us well, and I think they know it. They know it as well, and And I'm optimistic that in time it will change. And really, we only have, when we talk about social media and the people that are on it, you just have the extremes. The mainstream of our professions are really not as locked into one end of the spectrum or the other. Most of us are looking for how can we best apply what tool we have in our toolbox for the person that's sitting in front of us. I don't often run into the people in courses who are very adamant that it be hands off or hands on. Most people are. I want to know when to use my hands. I want to know when not to, and that's the healthy question
Yes.
to ask is when do I do this, and show me how to be better at what I do. And we're all seeking to strive that, just
Yeah.
to be better at what we do, because at the end of the day, all of this is really just to reduce the number of musculoskeletal conditions there are worldwide that are leading to opioid addictions and really, really poor quality of life. I mean, if we can stop that trend, that really is our role, right?
Yeah, for sure, for sure. Yeah. Now, one thing I wanted to just go over briefly with you is and that may be an impossibility, but it's your clinical puzzle. You've got a clinical puzzle image, which I've picked up from, now which paper was that? It was from one that you published in the Journal of Bodywork.
Yeah, 2007.
Stability, continence, and breathing: the role of fascia following pregnancy. And so the diagram, which I'll put in the show notes so people can see it, if that's okay with you. You've got within that, well, first of all, the title I think is very important, because you've got strategies for function and performance. And I think that positive spin on things, as opposed to strategies to avoid back pain, let's say, which would be more of a negative. I think that's quite an important thing that, you've titled it that. But then within the puzzle, you've got in the outer ring, you've got the neural components, the myofascial components, the articular components. So that's kind of a little bit Punjabi's model type inclusion there. But you've also got the viscera in there. So those are the four outer units that encase the middle component. And within the middle component, you've got the virtual body, the story, the emotions, the meaning, and the goals. And I just think that's a great model. It really fits with a lot of what I've come to understand of the important aspects of what a patient is coming in to see us with, and what they're searching for. But do you want to explain briefly how you put that together and why it's important?
So this was a graphic that Linda Joy Lee and I developed together, and it was published in 2007. And for a number of years, it was a reflection tool, or a way for students to look at the whole person and not just a joint or a muscle or the organ. With the whole goal being, and the encompassing ring around it being, to remember that what we are trying to change is function and a performance. And by changing how they are moving or performing or sitting or what they're doing, will often lead to better outcome. So that's what the graphic was to represent, that when you are going through your examination, these are key components of your assessment. So it begins with hearing the story of the person in the middle. And from the story, what you're trying to gain is there any cognitive dissonance? Is there any beliefs or myths in the story that you're going to need to address? Are there any medical conditions? Is there any emotional impact on this? So we are trying to get the three dimensions of the person's experience: the sensorial dimension, in other words, where do you hurt, what makes it better, what makes it worse, what do you believe is going on, and your cognitive beliefs around it, and how has this affected you emotionally. And then from that, and the whole person in the middle, you're going to get the task that you want to work on, because strategies are task specific. The evidence is clear that motor control and strategies are unique to the individual, and they are task specific. So we can't just look at, if you have back pain, we can't just look at forward bending, because if you get back pain with walking, nobody bends forward when they, well, some people bend forward when they walk, but they shouldn't be.
Yes.
So anyway, you pick your meaningful task from that. And then on the outer circle is where the tasks go. So you may look at a standing starting position screen, and then look at one-legged standing and thoracic rotation, two screening tasks that would be useful for walking, if walking was the task that they wanted to work on or to improve their function of. So in the outer wheel of that clinical puzzle is where you write your findings in the sense of your alignment, biomechanics, and control, and finding drivers. So that kind of gets charted in the outer wheel of that circle. The inner pieces are what your further assessment of that body region. So let's take our hamstring guy again, and let's say that we decided that that his pelvis was really, the motor control in his pelvis was the problem. You compressed the pelvis, his leg popped up, you went, right, I need more information about this pelvis. Then your further tests of active and passive mobility, active and passive control, are sort of your four main tests, headings of tests that you need to have in your toolbox, would then differentiate for you whether or not there was a problem in the articular system. Can the joint move? Is it well controlled? The neural system, which is huge. It's where all the motor control stuff and neurodynamics and virtual bodies have all lived. Do you have a problem in the myofascial system? So the myofascial system speaks more to the structure. Has there been a fascial tear at the insertion point of the hamstring? Is there a bleed in the muscle? I mean, you ruled that out with your test with your active straight leg raise, but that'd be the myofascial. And then the visceral, is there a visceral component contributing to the motor control strategy you're seeing? So IBS, cystitis, endometriosis, or any of the Boral stuff, which is looking at poor mobility or movement of the viscera relative to one another as you move from whatever it is that have caused them not to move well. Now, there are more. We started with this in 2007, so that model's quite old now. But they were the main ones that were appropriate to physiotherapy. So you notice there's not a lot of gut health on there, although I suppose it could go in the visceral component. But you could start to expand and develop more and more systems. But it was a starting point or a way for us to start to organize information that was really relevant to the scope of practice of physiotherapy anyway. And you could probably have a clinical puzzle that was a little bit broader or different for osteopathy, but a way of helping to develop a closet organizer, if you like, or a structure, a way of organizing the information that you get from your assessment. And it's a reflection tool. It's a tool that if you're struggling with somebody, you can sit down with a puzzle and fill in the blanks and kind of go, oh, I missed this, I missed that, I should have asked this question or that question, to sort of bring some clarity to somebody's whole story and perhaps help to illuminate what the pathway is to change.
Yeah, that's fantastic. Really good. Yeah. So, and of course, it ties in a little bit with the paper that we've just co-written for the Journal of Bodywork and Movement Therapies. So the paper's called Thoracic Ring Function, Movement Efficiency, and Injury Prevention. And you know what I'm tasked with doing for the Journal of Bodywork is to pick out a couple of papers that we want to include in the rehabilitation section, and then to write an editorial on those papers. And so I asked you, Diane, to help to co-write this paper. And so we picked out in particular a paper by Morley and Traum, and essentially they were looking at how restriction of a sort of artificial restriction of the trunk using some kind of brace affected gait patterns. So do you want to talk a little bit about what you wrote there, because it was quite an interesting
Sure. So I kind of drew from the motor control research that was summarized by Hodges and Smeets in 2015, which notes that multiple studies have shown that motor control changes in the trunk in response to pain are highly variable, number one. And the consistent finding is there is this redistribution of muscle activity, with the deep muscles becoming inhibited and the superficial ones augmented. And the redistribution of muscle activity, clinically, what we find is that it leads to rigidity. So while the superficial muscles can stabilize us, they prevent us from moving well. And that essentially is like casting the thorax. And so what we found clinically for years now, and LJ started this work years ago, is that the this redistribution of activation can affect like one fascicle of the external oblique or one fascicle of iliocostalis. And that can impact the mobility of one rib, which will then impact an entire ring. So all of a sudden you've got one ring in the thorax that's rotated to the right. And if that muscle won't eccentrically lengthen or relax and allow the rib to move as it needs to move for left rotation, then that ring will stay in right rotation when you turn to the left. And if you've got multiple like that, if you've got several rings that have been hijacked by various different muscles. What you see in the spine is a person who turns, and instead of having a beautiful long concave curve in their spine, they've got multiple kinks in the curve, multiple things going left and right, left and right, left and right. And this is essentially a casted trunk. It's just the rings are not dancing or moving in the same direction as that they need to. That's how we then applied that clinically, and then went to say, okay, so which one's the relevant one? Which one should we start to change? And this is this whole thing about finding the relevant ring, because some of those are going to be compensating for the relevant one, and when you change them, are not necessarily going to change the clinical presentation. So just like your active straight leg raise guy again, if the pelvis wasn't the driver, compressing or controlling the pelvis wouldn't have changed his pain experience, wouldn't have changed his functional ability to lift the leg. So here in the thorax, if we're looking at thoracic rotation, which is an essential component for a runner, it's really how we get our drive and force for running. If you can't rotate your thorax incongruent to the pelvis, that's really relevant. So this was me trying to draw an analogy between how casting the trunk in an experiment is actually seen in clinical practice, and using the motor control evidence to support what I see clinically, or we see clinically within the thorax.
And essentially what Morley and Trauma were suggesting, and what they measured, was that, of course, this then leads to fatigue sooner, because they're actually measuring oxygen uptake, and then, of course, fatigue may lead to compensations elsewhere in the kinematic chain, and or increased risk of injury, or certainly lower performance. So just a fascinating sort of insight as to how you can artificially create that bracing, but then the body can equally cast itself in some instances, and that's obviously going to have a knock-on effect, which it seems you've managed to effectively counteract at Manchester City, which is fantastic. Exactly. Yes, exactly. Great. And then there was another study within that paper which was looking at motor control, as they say, core muscle activation exercises versus conventional treatment, and that was looking at it in respect of patients with knee OA. Now, I don't know if you want to expand on that aspect of it as well, but I think essentially it ties in with the same discussion, that when there's altered motor control at the core, or altered force transfer at the trunk, then that can potentially have an impact into the lower limb as well, and therefore create asymmetric loading and stresses through the lower limb.
And over time, the hypothesis is that this can wear the joint out. So the knee is particularly vulnerable to areas of the body that lose their rotational ability. So subtalar joint, hip, and thorax. So in those three areas, when something mucks up your subtalar joint and it can't rotate well, or your hip, or your thorax, then the lumbar spine and the knee really have to take on more responsibility for rotation, and neither the low back nor the knee are designed to rotate. So that can be a reason why they start to get grumpy, or start to even get arthritic, but even just changes of center mass over base of support. So if the thorax is now not sitting stacked on top of the pelvis, but is lateral translation couples with rotation. So when the thorax rotates, it translates to the contralateral side. That's Punjabi's work from 1976 as well. And so you get a displacement of the center of mass off of center. And so that's going to load one compartment of the knee more on one side than the other, right? So the more medial, if the shift is to the left, it's going to be more medial compartment loading of the right knee, lateral compartment loading of the left knee, which again sort of sets you up for potentially having some wear and tear down the road if it's not addressed. So we do see the victims being the neck, the back, and the knee, and the perpetrators often being the foot, the pelvis, the thorax, and the cranium. How we tend to see the patterns, for sure.
Excellent. Yeah, thanks. So, well, that paper is going to be available. It's already available online, but the issue, I believe, is coming out in the next couple of weeks, and so you'll be able to see that there online. We'll also be sharing what's called a share link, which I think for 60 days means we can actually share this paper for free. And if you're on any of Diane's courses or on anything with me, then we're allowed to also hand them out to our students, which is great. So, but I'm sure also if you contact us directly, we'd be happy to share the paper as well. But Diane, I was just thinking we could finish off perhaps with a little bit of wisdom from you in terms of when people are coming up through physiotherapy school or osteopathic school, and of course we're all exposed to the online world and the social media world now, and so I think it would be quite confusing if I was back at college now, because there's so many disparate ideas and opinions. And this is why I call the podcast From Chaos to Order, because what we're trying to do is to find some order amongst the chaos. And I think that's where someone with your level of experience and having seen the trends come and go can give a little bit of wisdom to those that are just making their way on the early phase of their journey.
We're starting to see, at least in Canada and British Columbia here, a lot of new grad physios opening practices as soon as they graduate and get into business. And I think that's the wrong step. I think the first 5 years after practice is you've just been given a license to learn. You have some tools, but you don't have zero clinical experience yet. Find yourself a mentor. Find yourself somebody that you really resonate with, that works the way you look at it, and you go, I want to be like that person when I grow up. I want to be able to do that. And then, spend some time with them if you can. Take some time and put yourself back into the seat of the student. You need to, you've graduated, you've got a closet with a few tools in it, but not a lot. And I like to see therapists who take my courses after they've got about 5 or 6 years where they've gained some clinical experience and their closet is really messy. They've taken tons of different courses and all the stuff is all on the floor and they just don't know when to do what to help organize things. But you need a mentor. We need mentors in our lives, and we can't be running businesses and looking after staff and human resources and worrying about the lease and the rest of that if we really want to develop good clinical skills. So take the time, give yourself the gift of time, find yourself some mentors, and keep following the evidence, but build your clinical tools and don't forget those hands. Your hands are a powerful, powerful tool. That would be my biggest recommendation.
Excellent. Fantastic. Well, Diane, thank you so much for your time today and for all of your work. It's we barely touched on most of it, but it's been a huge inspiration to me to be able to both read your books, come on your courses, and to do this paper together and the podcast together. So thanks so much for all of that. And
thanks for mine as well, Matt. Thank you.
So Diane, before we wrap up, could you just let the listeners know where they could find out more about your own work?
Yeah. So if any of you are interested in any of the online courses or material that Matt's been referring to, I encourage you to check my online education workshop, which is Learn with Diane Lee. Come and play with us.
Fantastic. Yeah, and I can highly recommend it. Okay. Thanks, Diane. Take care.
Thank you, Matt.
Bye-bye.
Bye.
Well, I hope you enjoyed that chat with Diane as much as I did. Diane is such an insightful and innovative practitioner, and this shines through in her books, presentations and courses, which are well ahead of the curve, as I'm sure you've sensed as we chatted through Diane's highly decorated career. What appealed to me most about Diane's approach is her open-mindedness and her ability to integrate cutting-edge conceptual information with highbrow leading research science to create one of the most innovative and effective rehabilitation programs on the planet. If you enjoyed hearing Diane just touch on the importance of the patient's story and their meaningful tasks, then you will love both the recent podcast I did with Bronnie Lennox-Thompson, episode 16, and the upcoming podcast I have with Dr. Nick Penny, who did his doctorate in the biopsychosocial approach to working with people, and in particular, the application of mindfulness practices to helping those experiencing persistent pain. Both Nick and Bronnie are based in New Zealand, where I'm headed in March 2020 for a 2-day seminar called 2020 Vision, Putting Persistent Pain Behind Us in the Next Decade, which aims to provide working clinical models to help the health or fitness professional effectively apply what is most current in the scientific literature within their working environment. Further details can be found on the show notes or at mattwallden.com. Just search 2020 Vision. Looking forward to seeing you, perhaps with your 2020 vision already secured, at the next show.